This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only. And because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome back, everyone, to another episode of the Not Your Doc podcast. It's good to be here once again with Mr. Not Your Doc himself, Dr. Charles Tadros. How you doing today?
Very well. Nice, bright, sunny day here.
I know, it's lovely.
St. Louis is appropriate for the middle of winter.
Yes, exactly. After our kind of wimpy snowstorm that came through yesterday.
Anyway, from 3 to 5 to 7 inches or 10 inches, and it was probably less than 2.
And it barely even got below freezing, so it was just slop falling off the trees.
It's all right. It's safer for driving. Not much fun for sledding.
Yeah, that's true. We didn't have to move any patients around, and that makes me happy.
We're here today with Seth Gabriel from Benton Park Media.
Yes. Absolutely. Our producer, Seth. And I'm Vanessa, of course. So we are going to kick it right off. So I'm looking forward to our topic today because it's one that we sort of teased in the first season. Mm-hmm. One of the purposes of your wanting to do this podcast, Dr. Tadros, was to help empower people to take charge of their own healthcare. Mm-hmm. And to contribute to that, you are helping us pull back the curtain on what can be a very opaque and hard to navigate system. Mm-hmm, mm-hmm. So many commonly experienced healthcare problems such as stomach pain or tiredness can have many causes and even more possible treatments.
Yes.
And I think most people listening to this will be able to relate to the frustration of going to the doctor for, anything less straightforward than like a sinus infection or routine screening.
Right. And
then leaving without the feeling that they have a satisfactory explanation or a solution for whatever symptom it is that they're experiencing.
Yes.
So I think that I think that from my perspective as a non-clinical person, I was trying to think about this, what really are the major roadblocks for, regular non-medical people like me, when we're trying to find an answer to some sort of symptom that's bothering us that isn't very straightforward. So I think there's three issues that really come up. So the first one is that, as untrained professionals, we aren't privy to the thought process that clinicians use to systematically rule out options, make a diagnosis, and suggest treatment. And one of the things, especially you talk about this a lot, is that, as regular people, we tend to make sense of our issues by sort of assigning our own meaning to them. And that's not a very scientifically sound way to figure out cause and effect for any of our problems. But so, just as patients, we typically think, I think, what I ate is related to how I feel, or how I moved, or my activity is how it related to how I feel. And clinicians are trained to think differently, and we just don't really understand that thought process. So that's one.
Yeah.
The thought process is new for us. Number two, we don't have the clinical knowledge of diseases and disease processes to understand all of the possible causes and treatments for our ailments. So that kind of goes hand in hand with the first one. We obviously didn't go to med school. And the other thing is we also don't know what can happen if we leave our ailment untreated, right?
Yes.
We can kind of assume that, if it's something that doesn't bother me that much or that I can comfortably get over, that it isn't something worth exploring. And, obviously that's not always the case.
That's right.
So the thought process, clinical knowledge, and then third is we aren't well versed in the structure of the healthcare system. And that's the one that we have to navigate in order to get the ailment accurately diagnosed and treated. And so this is everything from insurance to hospital systems, medical groups, specialists, and labs. I can, speak personally with this, that I have a tendency to become so overwhelmed with the necessary steps, the number of visits and phone calls, not to mention the costs, right? The actual money you have to spend on this.
Right. That's a good point.
On finding appropriate care, that I just sort of shut down and choose to, accept whatever this thing is that's bothering me as just part of life, because that's a more comfortable alternative than to like willingly engage in this process that brings me so much stress.
Yep.
But once again, this can have deadly consequences depending on what the actual issue is itself. And so I'm just so grateful that we get to pick your brain today, and you can help us sort of illuminate, why this is important to you as a physician.
Thank you. Yeah, thanks for bringing it. These are all, I like the way you've structured it, and there's 100 different ways we can go about this, but we're going to get through this, and hopefully we'll come out the other end with some clearer understanding about, and also know your resources, and that's just like I have to look at resources. You'll have resources to look at too, more consistently. Yeah,
for sure. So I think, Dr. Tadros, I've come up with or you and I have come up with a good way to help listeners sort of like work through this progress and process and sort of think about these roadblocks. And we're going to use an example, a patient example of, and in this case, we're going to do acute low back pain. And you're sort of going to walk us through these different roadblocks. So the thought process that the clinician used to treat, clinical knowledge, and then also how to navigate the healthcare system to get something like this addressed.
Yes.
So, with an eye to those things, or an ear to those things, since we're on a podcast.
Sure.
Tell me your thoughts to start with. Have I framed this up appropriately? Do you think we're going to be able to accomplish? Is there a reasonable expectation for us to be able to accomplish this goal?
We won't be able to cover every possible angle, but that's part of my message, is that you don't need to know everything and think of everything in order to get the most common things correctly understand. So I think that's an important piece, that you don't have to be top of your med school class in order to understand, or nursing school class or nurse practitioner, in order to understand the common things. So we picked a fairly simple, not quite straightforward, low back pain as just kind of a case, what we call case study. So what we do in medicine, and they do this in business school and law school, they pick cases, and from those cases, the different decision points and different pieces of information, you can branch off and to understand a lot more than just what's in the case. But what anybody in any profession, engineering, culinary, you're always interested in the possibilities, whether the most likely to the least likely possibilities, if you can arrange them in that rank order. But what you're always interested in is understanding your resource, what we're talking about, so naming it as best as you can, or initially naming it, and you can always change it later. And number two, your resources, whether it's people or websites or books. And number three, your what we call in medicine differential diagnosis, the list of possibilities, and typically we want to know the most common, most likely thing to happen. For instance, lung cancer tends not to happen to a 12-year-old who just started smoking, but it may happen to a 65-year-old who's been smoking for 30 years. So certain things that we worry about are more common in certain groups. So we call this a pretest probability. And we'll talk a little bit about Bayes, B-A-Y-E-S theorem, and eventually we'll talk about it actually separately. Because this is the way kind of how we assess, whether physicians realize it or not. This is how we assess risk as we get more information. And so that's what we automatically do without actually naming it sometimes. So anyway, I chose kind of an aggregate of a pretend female patient who's an aggregate of many patients that I've had in the past, including my low back pain. So I'll start there, if it's all right.
Sure, please. Right. What's her name? Can we give her a name?
Well, what would you like to name her?
What about Layla?
Layla it is.
Layla is our patient today.
Layla. All right. So Layla, this is. So I'm going to say it kind of in a format. It's not quite the format that we would do it in med school or residency. Med school is after 4 years of undergrad. Is considered graduate school, and then residency is a postgraduate kind of a program. So med school. So there's an old-fashioned way of doing it, but I'll do it a little newer. But so we'll call Layla is a 27-year-old female in her usual state of health. We don't know what that is, but we'll come back to that. It was in her usual state of health. No prior falls or accidents or traumas that have affected her low back pain. Her chief complaint is low back pain. I should have started like that. She presents to her primary care physician's office, this is an internist in this case, with 10-day history of right low back pain. She states that she was getting out of her car at the airport, was bending down to pull out a 25-pound roll-on bag when she felt a sudden sharp pain in her right low back and heard a pop in that same area of her right low back pain. It was right above her waistline, and it kind of made her collapse a little bit to her knees. She states that the pain was right there above her waist, above the pelvis, right on the right low back. It did not shoot anywhere, did not radiate anywhere, didn't radiate down her leg, didn't radiate into her pelvis or her abdomen. She had no associated fevers or chills or rash or shooting pains. You want to go over kind of that statement and just kind of break it down?
Help us understand what you're saying there.
So everything, and we should, and people put in excess information that's not useful, but in this case, a 27-year-old gives us a hint that young or relatively young. So we tend not to think of old person diseases like aneurysms that can cause back pain and cancer. So that's the first
or
thing.
Osteoporosis.
With
the bone issue.
Bingo.
Okay, yeah.
Female. So sometimes females have different causes for low back pain than men, because sometimes what we call referred pain from the pelvis, ovaries and fallopian tubes and uterus, which the men don't have, can also sometimes radiate into the lower back in certain situations.
When you say radiate, the pain radiate, what does that mean exactly?
That's right. So it's called referred or pain. So even though your ovary is in the middle of your pelvis down low, it can shoot pain into your back of your pelvis or to your low back, as if, and you've heard, for instance, pregnant women, if they have back cramps or back labor. Well, their uterus is not in their back, but that's whenever they have a baby in the uterus and they're having contractions, they can feel it in the low pelvis and the belly, but they can also feel it in their back. So it's called referred pain or radiating pain.
Okay.
So it's
and that's a function of how the nerves work,
that's
right?
Okay. That's right. That's exactly what it is. Is because the same the nervous system that innervates the uterus. In this case, also innervates areas on the back.
Gotcha. Okay, thank you for clarifying.
Yeah, same thing, by the way, with heart attack patients. They sometimes think that they have gas or indigestion because the heart and the stomach can share some of the same sensory nerves. So kind of your body confuses the two, or it's easy for you to confuse the two because they share the two structures that are unrelated. The stomach and the heart share some of the same nervous system.
Okay, that makes sense.
So female, so we think about female organs. Usual state of health, that means nothing. That means she's nothing acute. That she's been stable in terms of her health. It could be terrible health, but she's stable, and no prior falls or accidents, and so nothing, no traumatic incidents, no falls off of ladders, etc. And she presents to her primary care physician's office as opposed to the emergency room. Gives you a hint that it's probably not an emergency. Oftentimes because they're able to. She waited 10 days. Sometimes it's because the physician's office couldn't get her in any sooner. Sure. But sometimes it's because they can self-medicate or self-treat away from there, or they're trying something else with another practitioner. We'll hear about that. She said the mechanism of action, which was she was getting out of a car, she was twisting and bending to grab a 25-pound thing that was not at the center of her mass, but extended, where she had to extend her arm to get it out of the back seat, and twisting. So twisting and bending, put a high torque on your low back.
Okay.
And no fevers or chills, so it tells us probably less likely to be infectious, and a couple of different types of infections can cause low back pain. Rashes like shingles, or shooting pains where it was such a bad injury that it was compressing nerves that was causing pain to shoot away from the low back where she heard the pop and the initial pain, but it was shooting down her leg, for instance, sciatica and other nerves that would be trapped by discs.
Okay.
So that's kind of why we say these things.
Yeah.
No history of kidney stones, because kidney stones pain can start if you try to pass a kidney stone. And I've been fooled more than once. Somebody says I bent over and all of a sudden they had back pain, and we later find out it was not just because they're bending over. It just happened to be that they were starting to pass a kidney stone.
Wow.
And that's so we were misled by that. So so no kidney stones. We oftentimes we want to know the kind of what, when, why, how much, and what makes it better or worse. So the kind of the all the questions. So the next thing is what increases the pain is with coughing, sneezing, laughing, bending to lift. Those are called, we'll call these Valsalva maneuvers. These put increased abdominal pressure. So cough and sneeze and laugh. Those are typically, you tighten your vocal cords so that you force air through a tight area, and that also has back pressure that you can actually into the nervous system and also into your abdomen. Okay. And then bending and lifting is a mechanical, kind of simulates kind of what she was doing. It tends to be the pain in the right low back tends to be better with heat and reclining. So kind of in the reclining in a recliner or sofa or even in bed. Which is an appropriate sign for musculoskeletal.
Why is that an important thing to identify? What makes it feel better? Can that be a red herring?
Sure, it can be, and we can talk about that. But certainly, so for instance, Motrin or Tylenol is oral pain analgesics and anti-inflammatory. Tylenol has people misconstrue it as having the same thing as Motrin. Motrin is the same as Advil.
Right.
So
acetaminophen and ibuprofen.
Right. So acetaminophen is Tylenol. Ibuprofen is the Advil, Motrin. Tylenol is an analgesic, a pain medicine, and non-steroidal, doesn't have any steroids in it. And it's kind of a pain medicine, analgesic. Whereas Motrin, which is ibuprofen, and same thing as Advil, is an analgesic anti-inflammatory. So it has pain and inflammation. So it's not the same. And they don't have the same potential side effects for stomach and kidneys and blood pressure.
Sure.
And it turns out that Motrin and something that she got from her mother, Flexeril, a muscle relaxer, tended to help also. So what also made it better was heat, reclining, and Motrin and Flexeril. Heat we think of as something, whether it's hot tub or hot pad, is something that helps relax the muscle. So the patient, what we're going to talk about next is a little bit more about her. Patient is now working as a book editor. She doesn't exercise formally, but she does walk her dog for about an hour a day. She lives with a partner in their condo. She states that she is seated most of the time whenever she's up and around and awake because of her work, and that when she was in high school, women tend to stop growing height-wise about age 16, boys about age 18. So let's say she's a fully grown woman. At senior year in high school, her weight was 165 pounds, which is 25 for the body mass index. At 5'8", I'm sorry I didn't mention that, 5'8",
Sure.
165 pounds. And she also played field hockey and basketball. And then, so she was active in high school. Now, so she's now 27, so she went from 18 to 27. She's 185 pounds, so she's a body mass index of 28. So at a body mass index of 25, she was right, and she was probably quite athletic. We don't know what her percent body fat was, but at 25, it's right at the borderline of being overweight. And at body mass index now, at 185 pounds, her body mass index is 28. So it went from 25 to 28 for the body mass index. She went from borderline overweight to overweight. Weight impacts health of your back.
Sure.
She does smoke tobacco, and it turns out that studies have shown that the amount of cigarettes you use and for how long you use it increases your chance of low back pain. So believe it or not,
interesting.
Yeah, smoking. There are a couple of theories behind it. Everything that smokers may be more sedentary, that using nicotine products may work to break down elastic tissue, part of what's in your disc, in your low back. Patient has normal and regular menstrual periods, although mid-cycle, which is about the time of ovulation, she will occasionally get sharp pain in either right or left pelvis that doubles her over for about 36 hours. She's this is right whenever she's ovulating. She's been to the emergency room twice in the last year, but still has not followed up with her GYN. The ER had not found anything.
Sure.
She is gravida 0, para 0, abortus 0. So gravida means how many times she's pregnant. Para is how many babies she has, and abortus is how many babies that were either spontaneously or voluntary abortions. That helps us a little bit with some of her GYN health and history. She's had 5 UTIs in the last year and a half. They've been treated over the phone. She has so uncomplicated UTIs. So she's not really ever had a urine dipstick for UA or a urine culture, but treating her over the phone for typically 3 days at a time. That's all you need typically antibiotics for uncomplicated UTIs. It's not up in the kidneys. It's not associated with STD. That's been so she's been able to do that, and UTIs have never affected her back. She's on these medicines. She's on Prozac. She's on Motrin, which is just recent start, so the last 10 days. And the muscle relaxer she grabbed from her mom. Her mom offered to her is called Flexeril or carbamazepine, cyclobenzaprine. So she's on those medicines. She's already tried in the last 10 days a chiropractic treatment, which has helped for a few hours after each one. This is called high velocity manipulations, low amplitude. So it's called high velocity, low amplitude. The idea of the cracking or snapping that you sometimes hear if you watch TikTok videos and stuff like that.
Has she had any traction therapy done?
She's not, as far, I did not ask her that. Okay. So in this case, we don't have. And she's had heating pads also that have helped, like I mentioned. Family history is just significant for her mom, who has had back surgery for a disc that was compressing a nerve that was shooting down the mom's leg. So her mom has had back problems also, but more serious than the patients, her daughters. She required surgery. So the vital signs, so that's the next is the physical exam. Vital signs, that's the blood pressure, pulse, which is heart rate, beats per minute, temperature, sometimes oxygen, sometimes pain scale. So vital signs are acceptable for her age. Temperature, she's afebrile, means no fever. Her weight's 185 pounds, like she had stated. You examine, so typically we have the people, we step out, we have the people undressed to a certain level, so whether it's a paper gown or cloth gown, we want to be able to see the skin, the posture. It's hard to see whenever people have clothes, especially layers of clothing on. Unfortunately, what's happened over the years is what I've found is more and more physicians tend not to undress their patients appropriately with appropriate cover-up and stuff like that, because it's just easier to listen to your heart through your clothes, or just open up just pull down your T-shirt and I'll just listen and stuff like that. So I find that we not only we don't do the exam for what we're looking for as well, but we also miss other things like a skin cancer, or melanoma, or something else that we could see whenever we're looking at, for instance, in this person's back. So in this case, the skin over the torso looks normal. No rash that goes with shingles, which is old chicken pox that lives in your nervous system. The patient's in mild distress because she's kind of bent over at the hips a little bit, at the waist, and whenever the gait. So when the stance and the gait, the stance is how the person stands. In this case, the patient standing with her right posterior pelvis, the back of her right pelvis, a little higher than the left, so it's tilted up. We take this, it could be old, it could be something that she's already had for years, or it could be spasm, that you're spasming the muscles on that side to protect.
So she's kind of favoring one side or the other.
That's right, bingo. Right. And the gait just shows that she's kind of limping a little bit, because you could tell she doesn't want to jar her back by walking too much. Right. And she's holding her right back with her hand a little bit, kind of putting pressure on it. Whenever you look from the side, pelvis is tilted forward. That's potentially due to a couple of things, but potentially due to her weight. It will tilt the pelvis forward. So her pelvis is a little bit higher on the right than the left when you look from the back, and when you look from the side, her pelvis is tilted forward. When you go to physical therapists and they look at some of that stuff, that's some of the stuff they try to work with you to correct. And they look even further to leg length discrepancy, your arches, and some other things. Whenever you have the patient bend forward, it worsens her right low back pain. When you have the patient extend or bend a little bit backwards, it worsens the right low back pain. Twisting at the waist, however, does not worsen the right low back pain. Whenever you palpate or touch the vertebrae, the back of the vertebrae, they're not tender. But if you go to the right, where the muscles and the ligaments are, right of the low back vertebrae, it's tender there. Whenever you have the patient seated and the legs are dangling, not touching anything, you can use a reflex hammer and tap their knees, the patellar reflex, and that's equal. That tells us about this, what we call the spinal reflex. This is you don't need a brain for this. All you need is nerves to your knee, to your tendons in your knee, and go to your spine and come back to your muscles in your thigh. And so you could tap that, and that tells us that the circuit that is intact. So the knees are
unlikely
intact.
that she has a spinal cord injury that's causing the pain.
Of significance, or a spinal nerve injury. That's correct. That's very good. So both the knees. So that's so that tells us the reflexes are L4, L5. So the lumbar fourth and fifth nerves innervate the reflex there, and then the reflex of the ankles, which is about sacral nerve 1, the first sacral nerve. Those are normal, that tells us that also. So those are some of the lower part of the low back nerve reflexes.
Got it.
Yeah, it's very good.
Okay, so Layla has gone to her primary care physician, complaining of low back pain. So this sort of like physical exam, the history of the present illness, some of her medical history stuff, her family medical history, and then also how she's presenting in the moment from the physical exam. These are all. Not all of these pieces would be like checked by the doctor. Like some of it might be stuff she reported either like in her chart upon check-in or that the nurse asked her about when she was checking in, correct?
That's exactly right.
Okay. So when Layla is finally face to face with the doctor and he has this information about her, we kind of went through like, you're going to talk to us more about the disease process in a second here. So what other things, like other than like her existing medical issues, might be going through his head at the time of this consultation?
Sure. So a variety of things. So first of all, is it real? Is everything that she's described real? Is it consistent? Right?
Can you talk more about that? Yeah.
Well, so there's a variety of things. Number one, some people are malingering. This is not the first thing that we think of, by the way. It's probably much, much later, sometimes several visits later. But some people are malingering. They don't want to go to school. They don't want to go to work. They want to establish a paper trail of an injury that they're going to want compensation for, et cetera. So that's one thing. But that's not usually the very first thing.
Sure.
The next thing is, if she's minimizing, or any patient is minimizing, or maximizing some of this this stuff. So if and this is one of the things, and other physicians do this too. If they're laughing and twisting and turning in the waiting room, and then they walk back, and as they walk back, they grab their back and stuff like that. Gives you a hint that it might not be as bad as they're saying, or there may be an affective or an emotional component to it. So that's the first thing. The other thing, we don't want to minimize things. So a lot of people will minimize for a variety of reasons. They don't want to rack up a bill. Right. They don't want to stay around too long. They're worried that that they're going to have to miss out on whether sports. This is a big thing with it. Whenever my wife is a school nurse, and if the kids are sick, they can't play. If they miss school that day, they can't play that night. Yeah. And so they don't want to be sick. Right. So if they're fever or throwing up or whatever, so you got to go home. They kind of freak out because they're already wearing their jersey for that evening's game and stuff like that. So so you have to kind of think about all the angles of real human beings that have they have other gains and other needs, and it's not just about their back. Now, some people exaggerate the symptoms because they feel like they have to say something big in order to get attention. Yes. Not necessarily attention, everybody stops what they're doing, but attention because they're afraid they're not going to get good care. Sure. So that's the other piece of it.
And some of that can be based on their personal reality, or even
that's exactly what it is.
The reality of their families, or maybe even their cultural group hasn't been treated well in the past. So that's a real concern.
That's a real concern. It's very real, and it needs to be addressed. What I'm bringing these up not because what happens is we overtreat. We underestimate the danger or the significance, or overestimate the danger and significance. And both those things cost us time and money, sometimes health and lives. So we have to be careful about some of these things. And so sometimes when I'm reassuring somebody, in this case it's going to be pretty benign, when I'm reassuring somebody, I always want to tell them, but, and this is what ERs do, but if this gets worse, or if this changes, or this says, please come back, or please go to the ER.
Right.
Because what we don't want is, and what physicians have not said out loud, is that patients want us to be perfect. Maybe not for heart attack or stroke or something, they want us to be perfect right within the first few minutes. They don't want us to miss anything from the emergency room.
Correct.
But for something where it's not as obvious, they want us to they want us to be pretty definitively right within a couple of visits. Nobody says, my doc got close enough, but I suffered for 3 months. Nobody wants to say that. They want to say, I went back 3 times and I brought attention, or I told them something's different, or the medicine wasn't working. The doc said, hey, wait a minute, let's go backtrack and let's re-listen to what you said. Let's re-examine, let's re-discuss. So people want you to be right. That's their health, their life, their money, their time. And so there's, fortunately, some things just get better no matter what the doc says or does.
Yeah.
Viral sore throats, no matter what I give you, the vast majority of young, healthy people, middle-aged people are going to be fine.
Yeah.
So even if I'm totally wrong, you're going to be great. But the worry always is, just like you mentioned earlier, people are worried if they don't tell you a lot or tell you enough or tell you the right thing, that you're going to miss something. You're not going to ask further, and you're going to miss something. And it's because they didn't divulge everything that they could think of, that their mother and their grandmother. So anybody where I talk about today and they start back in 1978,
right.
I'm like, I kind of roll my eyes, because it's very likely something from 1978 affects you today in terms of your physical issues. But that gives me a hint that that's what they're worried about.
Yes.
They're worried that there's not going to be enough information for me to make a good decision and guide them in the right way.
Yeah. I think some of that ties in with, excuse me, just as regular people are desired to assign meaning to our issues. Excuse me. And come up with a reasonable explanation for what's going on with us. So that kind of begs the question, like, if, when Layla is in here explaining what's going on, one thing I noticed in your presentation of your case study, that all this is very like objectively observable stuff, either measurable or observable with the naked eye, or just pretty easy to corroborate, information that's fairly easy to corroborate.
Yes.
Does Layla need to be concerned that her own theory about what might be causing her pain or her injury or anything like that is not going to be taken into consideration if it's not covered in that?
That's correct. Because I'm an old doc, and I used to, what I do now, and you've heard me say it hundreds of times, I ask people, what do you think is wrong? So now some people take it to mean, oh my God, he went to med school and residency. Yeah. He doesn't know what is wrong. He's asking me. So that's the first thing. I've actually had people say, I'm not the doc. I'm not the... And so I have to go back and correct and say, no, I already have ideas of what's happening. Sure. I just want to make sure that I address, just like you said, what your worries are, what you think may be happening, what you think, because they link it to things that, like I said, from 1978, that has nothing to do with it, but in their mind it may have, and I have to address that specifically, or else they think I'm an idiot because I obviously missed the obvious connection that they knew about, but they never mentioned it and I never asked.
That's very clever. And a sign of a great doctor, obviously.
No. Well, it's just old doctoring.
Is it, is it possible that at Layla's appointment, her doctor can be, distracted by other things that are going on, trying to stay on schedule? I'm glad
you mentioned that. So these are hints. If you're on time or early, this is my wife is from old German. If you're on time, you're late. So if you're on time or early, and everything's delayed, you did not delay, you filled out everything and stuff like that, but it's delayed, whether it's the front desk or the doc or whomever, it's delayed. You can be almost assured that something is going to be either, even if it doesn't look rushed, it's in their mind or on their schedule, that something is backing up, it's going to feel rushed to them, even if it's not obvious to you, because they're good physicians, good nurse practitioners and stuff tend not to make you want to feel rushed. They want to make sure they address all your problems. You repeatedly ask anything else, but they recognize, if you give them really something big, anything else, that's gonna even put them further behind. So even if you get in relatively not within 15 minutes into the room, the doctor doesn't come in within another 5-10 minutes, because sometimes they'll move you into a room.
Right.
But
and
the
doctor, you wait more.
you could have just as easily waited out in the waiting room. So now it's a room without windows. So that's part of the problem that we run into. And we can make another podcast about how about some of these urgent versus chronic patient needs and conditions, and how we try to overlap. We take care of them in the same office visit,
time, yeah,
and
absolutely.
it tends not to work very well.
Sure.
It's important that somebody knows a lot about you in overall big picture, but boy, it just doesn't work out very well in scheduling wise.
Yeah.
Yeah.
Okay, so that kind of addresses like our the first roadblock we were talking about, which is just a lack of insight into the thought process that your clinician is utilizing when they're thinking about your problem. So let's move into the next one, which is the actual medical knowledge and the disease process itself. So Layla's in at this appointment with her primary care physician. He or she has reviewed all of this information in her HPI. He has listened to her account. He's observed her with his eyes. Now he's going to make some suggestions about what some of the possible causes are and possibly make a diagnosis. So what are the possible causes for low back pain?
And by the way, and the physicians kind of have a rough idea in their mind because they've done this hundreds and if not thousands of times. But the equivalent of what the internet will have. And a couple of good sites are the WebMD, MayoClinic.org, Cleveland Clinic, Harvard. There are a bunch of very, very excellent websites, and even by disease states, and it's written up in simple. For instance, I still to this day use the MayoClinic.org, and they have almost probably 60-80% of the diseases I look up. I can print out what I read and hand it to the patient, and it's up to date. It's pretty dang accurate. It's written in pretty normal English, with nice explanations of some of the jargon.
So you heard it here, folks. A real actual doctor is saying it's okay to look at WebMD or MayoClinic.com.
It's accurate. It's so big.
Yeah.
It's like, oh my gosh. But the answer is that's kind of the differential. That's the list of possibilities.
Okay, sure.
Now, yours may be one of those.
Right.
It's almost always going to be.
It's not
in
a
there.
diagnostic tool, but it's a list of
possibilities to think about and stuff like that. And then you kind of rank order them. What's the most likely? The most likely for a 27-year-old who heard her back pop and whenever she spun around to grab some suitcase, it's almost assuredly that she has a musculoskeletal, what we call musculoskeletal ligament, which holds bone to bone, or tendon, which holds muscle to bone injury. It's unlikely fractures, unlikely aneurysms, unlikely tumors, and unlikely kidney stones, it's unlikely shingles, it's unlikely a bunch of other things that could be listed. And so it's most likely musculoskeletal. And then you can go down that algorithm, that pathway of waiting it out and some other things we'll talk about. So I want people to kind of, because they don't know the differential, but WebMD and the Mayo Clinic will have the differential for them.
Sure.
Yeah.
Okay. So can I trust, or can Layla trust that her doctor, given that her injury seems very typical, can she trust that her doctor is considering all of the possible causes for her low back pain and not just skipping to the most likely one?
Unfortunately, and I know they say this in med school, you should just keep an open mind and open, I think it's Buddhist, a beginner's mind. You should keep an open mind about everything. But unfortunately, physicians, nurse practitioners, they're already assessing you before you even walk in. Like I said, if they see you in the waiting room, if they see you walking in some of my offices, I can see people walking in to my office, et cetera. I'm already assessing them. These are my regular patients.
Right.
They're not new patients. I'm already assessing them, but well before they step on the weight scale or before I see them in the exam room. So that's the first thing. So the answer is quickly no. The doc will not. The doc will zoom in on the most likely things quickly. First of all, by looking at your chart or watching you as you walk in, and then next this is where Bayes' theorem comes in. He'll get more information. He or she'll get more information as you talk, and then more information as they examine, then more information if they do X-rays or blood work. So you adjust the likelihood of different things happening or causing. Treatments follow, but the first thing is to name it and be able to diagnose it properly. Then the treatments are kind of algorithmic. They're kind of written out. They're not too creative.
Sure.
So anyway. And that's so you can't assume. And that's where the patient may say, "Hey, I read this on WebMD, and I know that this is more likely, but I'm worried about this because my great aunt had this, and I know that's not what you just mentioned." And the doc could say, "Don't look at WebMD," or that's they were from the old country and they didn't do it like that. And that's where. But for me, that was my joy was my ability to think and actually be stumped sometimes and say, "Let me go look it up. I'm not sure. I've not heard of that." Whatever disease or whatever else like that. So it's and I use my specialist, whether I picked up the phone and curbsided them. It's another term where you kind of get an informal consult. You kind of I'll run a fraction of what I would have said about this case in front of one of my friends who's a back surgeon or neurologist or pain specialist or physical therapist, and if I was stuck on something, and then you can certainly send them to a formal consultation where they have to get a.
So let me ask a clarifying question then. So it seems very likely that the cause of Layla's back pain is pretty straightforward and that the treatment would be pretty straightforward. A good clinician is also going to weigh her risk factors for other more severe things. That's right. And they're not just going to dismiss the fact that it could be this other thing that they're at risk for in favor of just taking the most likely option, correct?
Right. Yeah. So there certainly, if they have even though you're young, but they have a strong family history for hereditary colon cancer that shows up at age 20 or stuff like that, they're going to take that into account, even though it's very, very unlikely still in her that she has a hidden colon cancer is causing her back pain.
Right.
But that's part of the reason why you have to learn more than just what happened at the airport.
Right.
You have to know about the family history. You have to know that they're not losing weight. You have to know about all that's they're not losing weight because of a more serious disease. So all that stuff matters. The other piece of it is you always, this is the key, and this is important for people to know, because I have relatives that are afraid to call their physicians and stuff, is that the ability to get back to the physician or nurse practitioner or PA, whether by telephone or by patient portal or a follow-up visit. And that's key. Then we do this in our office for different reasons, but that you make a follow-up visit. Like, we expect this to be better in 4 weeks or 3 weeks or 6 weeks. So instead of calling back, which is sometimes it's appropriate, we'll make an appointment. Yeah. And if you're not better, I'll be able to see you and make an assessment that you need imaging or whatever. So as opposed to saying, well, call me when you want to. So sometimes that shows that the physician, nurse practitioner, physician assistant cares, that they recognize it may not be totally gone, that they recognize that you're very anxious. And so sometimes it's nice. Very few physicians will get on the telephone anymore. Right. So a lot of times it'll be on the patient portal, which has got significant limitations. So sometimes I'd rather have patients make an appointment. Yes, take up an appointment slot. Let me know 72 hours beforehand that they don't need to come in. Everything's much better. Cancel it so I can fill it with somebody else.
Exactly. Yeah. So I think we should put a plug in here for a second to for the value of good primary care and having an established relationship with a doctor that knows you. Layla could probably get the same treatments that we're going to talk about here for her low back pain from urgent care or an ER, for example.
A lot of times you do.
But they aren't going to, they're not going to be privy to all of this background stuff about, her recent health history, any of this, the stuff that you can only learn from having a relationship with a person for a longer period of time.
They do a pretty good job about getting the information, but you're right. People tend not to keep wanting to follow up with ERs. Right. They're big and expensive, and insurance makes sure that they're expensive because they give you a humongous copay if you don't get admitted.
Right.
So that's one of the things that's one of the sticks, as opposed to a carrot, is a stick. That if you go to a big emergency, regular emergency room, and you're not admitted, then it's a $200 or $300 copay and stuff
absolutely.
Like that. Plus whatever bills.
Sure. Okay, great. So let's go ahead and transition then to the next part of this, which is Layla's doctor suggests treatments, right? So this is kind of a question I think many people have when they're going into a doctor's appointment with a specific ailment. Let's stay with the low back pain. What's a reasonable expectation for when I leave the appointment that day?
Sure.
Meds, exercises, a back brace, referral to a specialist. Like what is reasonable for Layla to walk in expecting here?
Right. Well, so low back pain is extremely common, and they've done studies where if you walk into a PCP, primary care physician, nurse, internist, family medicine type of practice, about 1% of the people will have something. If you take 100 people with low back pain, acute low back pain like Layla's, 1% of them will have something serious and terrible. So 99% of them are going to get better within 4 to 12 weeks.
Okay.
That's still a long time.
Yeah, that is a long time.
But for us, it's still considered acute low back pain. If it's less than 12 weeks, there's acute and subacute, I should say. Then after three months or 12 weeks, then we start worrying about chronic issues. So that's the first thing. The next thing, well, remind me what else is.
Sure, yeah. Should she expect, meds or exercises or a back brace?
So unfortunately, there's so many things on the market because it's a chronic common condition.
Yeah.
So many things on the marketplace: stand-up desks, shoe inserts to help tilt give you better arches and tilt your pelvis, back braces, abdominal binders, all sorts of thumpers and all sorts of massage and all sorts of oils and all sorts of things. That's just stuff you could buy yourself without even a prescription.
Right.
Practically none of them have been shown to be helpful. Anything better than just plain old time and not even Motrin. So the American College of Physicians came out in, I think, 2017 and said, before they used to say just Motrin, Tylenol, they said nothing. For the first probably month, you can get away with zero, other than massage. If you want to do heat, cold, alternating, stretchings and stuff like that. So non-medic, not even over-the-counter products, let alone narcotics. Oh, by the way, that should be a big no-no. We should never start anybody unless it's going to be cancer or fracture or something that's severe. And this is not what we're addressing today. Nobody should be starting narcotics for this type of back pain ever.
Okay.
Even if it's persistent past 12 weeks. It should not be. It's a humongous problem. This is part of the problem we run into in the United States is that we're going to big guns. We're doing the Tylenol with codeine or hydrocodone or oxycodone products way too early for musculoskeletal injuries that may need physical therapy, may need time, may need wrapping, splinting, but we should probably not be using any narcotics on practically any of these. These are not bone breaks, or these are not cancer. Right. It's not cancer. Right.
Can you talk a little bit about the cost benefit analysis that the doctor is doing in their brain when they're thinking about which of these things? Because I'm sure they're taking into consideration how much pain, immediate physical pain and discomfort the patient is in versus the possible risks of any, medications or treatments or anything like that. So how does that thought process work?
Well, for me, the older the patient, the more likely they're going to have problems with the medications I would give them.
Okay.
So the young people tend not to have intestinal ulcerations, stomach or intestinal ulcerations from nonsteroidals. Older folk do. So if I give somebody Motrin or naproxen or Relafin, Nambitone, the risk of me causing an ulceration is fairly high, not fairly high, but higher with the older we get. So it's the first problem. The next thing is racking up a bill in terms of imaging. So X-rays, CAT scans, MRIs, so those are typical three. Occasionally we do something called bone scans, not bone densities, but bone scans for fractures and stuff like that. So it's almost, for this type of patient, they probably never, even 12 weeks out, they probably should not get, now unless something's worse. There's a difference between it not getting that much better versus worse. These people probably should not be getting any imaging, probably any, even basic X-ray. Now, if you end up in urgent care or ER, you almost invariably get an X-ray at least. They don't do MRIs typically in at emergency rooms, so either X-ray or a CAT scan, depending on what they're worried about. But almost everybody gets that. So that's why if you go to a primary care physician's office, they'll tend to treat you different, and they know you. They'll tend to treat you differently than urgent care or an ER for the exact same person for the exact same condition.
Interesting. So, okay, so then here's kind of like a follow-on question is, it's unlikely it's reasonable for Layla to expect that she's probably not going to be getting, narcotics for the pain, to manage the pain. She's not sent for a
Tylenol,
scan
right?
or anything like that.
That's right.
So what if, what are some likely suggestions that the doctor is going to come up with here?
Yeah, handouts in terms of physical exercises for stretching. You don't necessarily need strengthening just yet. Right now she's in a pain spasm cycle. The more pain you're in, the more spasm. Think of it as you wrench. So you twist and you either partially tear or you stretch a ligament or a tendon, and so the surrounding muscles tense up to make a kind of a splint.
Sure.
And so of course whenever muscles are tense around it, they themselves become painful, and therefore you split some more muscles, and so this is called the pain spasm cycle. So part of this is to avoid things that initially, not permanently, avoid the stuff that hurt, things that hurt. So that's the first thing. So if you're like, I have to pick up the baby, or I have to, it's like, all right. So now we're gonna have to figure out somebody else to help you, or the grocery, whatever it is, so that if certain responsibilities you can't discharge, that somebody helps you until the pain spasm is improved.
Sure.
And this is with typically with heat, massage, alternating heat and cold. Physical therapy even can be helpful early on. Typically, people don't. I tend to write for physical therapy early on because they start splinting and protecting that.
Yeah.
So they alter their gait, they alter what they, how they cough and sneeze.
Right, so it throws off a whole bunch of other things.
Right,
okay,
everything else. So I tend to have somebody who can monitor them whenever they can't get in to see me. I think is extremely important. And they teach them other things after the pain spasm is improved, so that you're less likely to be injured in the future if you have better core, which is your abdomen, your back, your buttocks, your hamstrings. It's kind of part of your core. Support your anti-gravity muscles that support your torso.
Yeah. Okay, so I think she would probably be told some red flags to look out for and reasons to return to the doctor.
Right.
What might some of those things be?
Some of them already would have happened by now, but so certainly if she has fevers or chills, that tells us potentially infection or inflammation.
Okay.
Infection, staph infection. We can get staph infections of our vertebrae, of joints in our back, epidural space, and inflammation, which is oftentimes arthritis, which is oftentimes not osteoarthritis, but inflammatory arthropathies like rheumatoid arthritis and psoriatic arthritis, etc. So if we have redness or warmth over a site in your back, or fevers or chills, we worry about infection or inflammation. So those are the first things. So if the other things are if your pain is worse with recumbency, so if you recline on a recliner or on your bed and you take weight or gravity, take gravity pressures off of your spine and you feel worse, that's not a good sign.
Yeah. What might that indicate?
Yeah, so sometimes that indicates a compression
Okay.
of a nerve or spinal cord.
Gotcha.
So that's some of the things that we worry about if it's worse whenever you when you lay down.
Yeah.
So that's the other thing with low back pain. If we call it saddle anesthesia, that's your buttock is numb. It's like it's the area that your buttock and thighs touch if you're riding a saddle of a horse.
Right.
So your buttock, your center of your buttock, and around your anus, and goes down into your thighs. It's called saddle anesthesia. It could go up into your labia or into the scrotum. So it's the saddle. That's the area that would be touching the saddle. That's a bad sign for something called cauda equina syndrome. It's a Latin term. Cauda equina is the tail of a horse. So that's after your spinal cord stops at about L1, lumbar first level. It sends up a bunch of nerves down into your legs and your pelvis. And so if those are trapped, the cauda equina, the horse's tail, if that's trapped by tumor, then that's a medical emergency. Whenever you can't pee or poop right, so it turns out that whenever we compress nerves that go to your bladder or your colon, you have either you're constipated, you can't poop,
because that affects peristalsis, right? Like the muscles that move all that through. Okay,
that's right. So if you can't poop or pee right, and normally you pee 3 times a day, and you poop twice a day, if all of a sudden you're not peeing or pooping for days at a time. Yes, it could be from pain medicine somebody gave you, or you could be in severe pain, and that could also cause it. But the other thing is tumors. Very, very rare, and usually it happens in people who've had cancer within the last 5 years. Certain types of cancers that tend to metastasize. So it's not usually the first presenting sign for a cancer for somebody, but it's somebody who's had a history of cancer, usually older folk. So if you have a bladder bowel retentions. You can also have urinary incontinence, so that you don't feel yourself leaking. That's the other thing. So urinary incontinence, urinary retention, we don't pee. Fecal retention, constipation, saddle anesthesia. Those are big signs. And then certainly the fevers and chills and it not getting better whenever you try to take weight off of your back.
Sure. Mm-hmm. So, what if? Okay, so it's possible for Layla to leave this appointment feeling a little bit discouraged,
yes,
right?
Right.
So, can you talk to us a little bit about like a good doctor's role
Sure.
in like managing expectations and normalizing certain types of discomfort, but also, being encouraging and having an openness to a next step or a second opinion or a specialist, kind of a plan if this doesn't help.
Yeah.
Can you talk more about that?
Some physicians don't want to open up because it just makes the visit just the first visit.
Yeah.
It's only been 10 days.
Yeah.
So from the physician standpoint, this is nothing. This is trivial. You're young and healthy. You're going to get better. Whether it's a week or a month or whatever, you're going to get better. But for her, because once again, it's dependent on her history, her culture, everything else of how disabled she believes that she is, how much it alters her day-to-day existence. So part of it is that some physicians, nurse practitioners, PAs don't want to tell you every single thing about what potential or potential for MRI 3 months from now, because it just takes too much time, and a lot of stuff can change in the meantime.
Right.
But some people need to know that you've thought about it, right? And so sometimes it's nice to write things out. And you say, if this, then that. So there's an algorithm, you can get it from books and stuff like. There's an algorithm that says, if this, then that, and if not this, then not that. So you can write an algorithm out. It's like, and you sometimes, because people remember parts of it, the parts that they're afraid of or they want to remember, then they will totally ignore everything else. So part of this is writing it out or having it pre-written out, because it's so common that people come in with this type of stuff. So you have pre-written out, you could checklist it, and then having an appointment to come back or to call back, whatever technique, or to enter information on the patient portal. Sometimes I've done what you just said. Sometimes in certain patients that I could tell that they're not just going to be happy, they need to see some gray-haired person with 50 years of experience at a university. I will give them the name and numbers
on a single type of bone or system.
Right.
Yeah, okay.
That's right. I'll give them a name or a number of a couple of people to say, you don't need to see them now, or you know what? Go ahead and make an appointment 3 months from now, so that you don't have to wait to get into university or whatever like that. But in the meantime, let's do this and this, and I'll see you this and that, and we have to do some other things before you see that person.
Right.
But sometimes that's enough of a Linus blanket, that comfort that they can hold to their chest, even if it doesn't do much. But it's just something important. Same thing with medicine. Sometimes say, don't use this medicine, don't use this steroid pack or whatever. I tend to use steroid packs as a big no-no. But once again, so don't use this unless you call me and blah, blah, blah. So it's important to give people and write it out in your own notes so you remember, because sometimes you don't remember what you told them or the order of doing things. But sometimes that's enough to appease people.
Sure.
And some people need to come back in a week, and instead of coming back in 3 weeks or 3 months. Sometimes they have to come back in a week so they can you can eyeball them again.
Yeah. So what if, obviously this is definitely an ideal scenario, and you're an excellent and very thorough and experienced internist, so this is the way that you practice.
At least for the podcast.
Layla may not be quite as lucky, or maybe she doesn't have as good of a connection with her physician. How can she advocate for herself if she leaves feeling like I'm not perfectly satisfied with this? Well,
one of the things, and this has only come after many years of me kind of wading through stuff, and I went through this recently whenever I went to see a physician. I want to know what I want to get out of the visit, and it's like anything in life. If you want to go to a lecture, what am I wanting? They usually tell you the objectives of the lecture and what the targets of the information that you're going to try to pass, so that you know what you're supposed to be getting out of it.
Yes.
So some of it is, if I say I need to get a specialist, or I need to get a narcotic, or I need to have reassurance it's not cancer, or I need to be able to go to come back sooner than later. So some of that stuff is important for you to understand yourself and be able to voice it out loud. It doesn't mean automatically you're going to get it, or you're going to get it from this person, or get it right now. But some of it is, otherwise you're just going to feel dissatisfied because you never voiced it.
Sure.
Which is a big difference than voicing it and they're saying, no, I see what you're worried about and I don't worry about it. versus like you never voiced it at all.
Right. I really like that. So kind of going into these appointments with a clarity of intention.
Right.
And maybe that's just to get your questions answered.
Right.
Maybe that's to find immediate relief for what you're experiencing.
Sure.
And those are reasonable intentions to have going into your appointment. So
and
that's
whenever the doc makes recommendations, they should always have a purpose or reason behind it. You know, I whenever I was looking at this stuff, I didn't remember that the American College of Physicians came out back a few years ago and said, hey, even Motrin is not needed for the first month and stuff like that. So because other stuff seems to work for me, sending early to physical therapy and nonsteroidals, but I'm probably over treating and therefore using up resources and putting a person at risk of stuff from nonsteroidal side effects from nonsteroidals. So I have to, we're always learning more. There's bigger and bigger data. There's better ways to crunch it and publish it. We get overwhelmed. I use resources like not more professional, something called Up to Date, which even regular non-medical folks can subscribe to. It's kind of expensive, but Up to Date is more medical terms. But it's one of the things that one of the resources that a lot of physicians use because it's an aggregator of information, of evidence-based information. And then there's something else that we use called the Cochrane database. Cochrane Review, Cochran, maybe. But anyway, they do evidence-based medicine reviews. And so there's some stuff out there that if you wonder why your doc is saying, or if the doc is not saying something, then you say, hey, I read this here, and I'm wondering why you're not don't believe in it or not following it.
Sure.
Yeah.
Okay, so we kind of established that, Layla's scenario is pretty typical. Let's assume that a couple of things were different and that, it was maybe more severe. So, and this kind of gets into the navigating the system part of it. So my doctor suggests other testing or non-drug therapies. So what are maybe the possible reasons to refer Layla to a specialist? So
right. Yeah. So some things I need to send her immediately to the emergency room. She comes and tells me that she's having fevers and low back pain, and I percuss or bang. This is you actually take your fist gently, the side of your fist. You could palpate or just push with your thumb down her vertebrae, or you could percuss, which is gently with the side of your fist.
Kind of a thump.
Thumping,
thump.
yes,
Yeah.
thumping.
Okay.
Yeah, that's it. Percuss, and she yelps, and so her vertebrae are tender, or she's had fevers or chills. Those people may need to immediately go to the emergency room. They not wait another few weeks to get to the specialist or a few months, etc. Some of these people is much more urgent. If I feel that her pain now, as I talk to her, her pain starts in her right low back, but now it's wrapping around into her groin, towards her uterus, towards her urethra and her groin. That might be a kidney stone that's trying to pass. So that tends to be more urgent, also because of the pain, because it could obstruct one of the kidneys or partially obstruct and can cause kidney damage that way. That's the stuff. Some people have shingles. They'll come in with back pain, and you're like, there's nothing there. And then 2 days later, they'll break out in a rash where you were looking or pressing, and that's oftentimes shingles, which is wraps. It's half. It's not usually bilateral. It's on both sides. Usually one side or the other side. Usually torso. It can be in the face. It could be elsewhere. I've seen it elsewhere on limbs and other places, but typically it's a torso, and it's usually one side. So it's a half. It starts with the vertebrae and wraps around the ribs, around the low back, and wraps around the belly. And so those people you want to know about sooner than later because you want to see them. You want to start them on antiviral medicine, which can help shorten the course and help prevent something called neuropathy. So there's something called post-herpetic neuropathy after herpes. This is not herpes. We used to call it herpes zoster, but then they renamed it many years ago varicella zoster, and so it's in the herpes family. It's very infectious, and it hurts like the dickens whenever it causes pain because it destroys the nerve as it comes out of the nerve. Yeah. And so those are some things that you want to jump on more quickly.
Could she be having any kind of like gynecological or obstetrical issue?
So an ectopic pregnancy may not show up. It'll show up typically as a pelvic. So ectopic, I should say, is that the egg, which is released from the ovary, is supposed to be caught. I call it caught with the fallopian tubes, and then the tubes shoot the egg down towards the uterus, the womb. But sometimes the egg is not caught by the fallopian tubes, or it gets stuck in the fallopian tube, and a baby starts growing and is fertilized in the fallopian tubes. Actually, technically, it is fertilized, and then it goes implants in the uterus. But if it does not make it all the way down to the uterus and starts growing a fetus in the fallopian tubes, that's also a medical emergency, because the baby's going in a very tight space. It could rupture and you could hemorrhage. Yep. So some of that will become sometimes pelvic and abdominal pain. Occasionally, it'll become back pain. So that's the other thing. What I alluded to here, whenever the patient was having pain during ovulation, so in between menstruations, is in the middle of it would be ovulation, when the ovary expresses an egg, pops out an egg, usually one side or the other. So 1 month is the right side, the next month is the left side. Usually one egg. If you put out more than one egg, you can get twins and triplets, etc. But it's usually one egg. But it's also whenever it releases the egg from the ovary, it releases a little bit of blood. So these people, it's called Mittelschmerz. It's an old German term, and so that hurts, like it feels like appendicitis.
Yeah.
That
same thing
hurts.
with like polycystic ovarian syndrome.
Bingo.
Too.
So if people hemorrhage into a cyst in their ovary, a chocolate cyst is what sometimes it's called. They could also have the same type of pain, pelvic pain, sometimes very low back pain, usually pelvic and abdominal pain. Yeah, that's the stuff. There are some conditions, there are some STDs that you'll get chlamydia of the fallopian tubes and have significant pelvic pain, sometimes in the back, low back, pretty significant, serious PID, pelvic inflammatory disease. So that's some of the stuff. There are some other things. You can get diverticulitis. Typically, it's in the low abdomen, low pelvic area. Occasionally, depending on where the diverticulum is, if it's pointing towards the back of the pelvis and attaches and stuff, it can cause posterior pelvis and low back pains. But it's pretty rare. That's some of the stuff. Sure. And then fractures of the vertebrae and osteoporosis. This is typically older people who've either been on long-term steroids, or older people who have thinner bones. The bone matrix, the bone architecture has been thinned out, and these people can just roll out of bed and crack a rib and crack a vertebrae. Right. Those hurt like the dickens, and they're very what we call point tender. You could push on one vertebrae, one rib, and it's pretty dang tender.
Yeah. Okay, so we kind of covered, some of those are emergency situations. Some of those are you're going to be sent to a specialist and they'll maybe identify them. Sure. Your physician should give you a referral. If they want you to go somewhere specific soon, they should give you a referral or call a referral into that office. What if they give you something general, like, maybe they prescribe physical therapy and they don't refer you to a specific specialist? Right. Is that the kind of thing you can utilize your resources through your insurance company to identify where to go?
Well, let me jump back for the referral. Sometimes they will, even if they want you to go see a specific person, they won't make sometimes they're very kind and make the appointment from their staff will make an appointment for you through the person. A lot of times they won't. It's a lot of time. They'll want you to go home and call, and then once you call and make an appointment with that specialist, then you call back your primary care office, and then they will, because the referral is very specific for a time and place and a person. Okay. So they want you to know where you're going to be going and what dates and stuff like that. Then when you call back primary care, then they'll send the referral to the insurance company. Referral just means, in this case, this is a formal referral. It just means that the primary care doctor is telling certain insurance plans, not every insurance plan requires a referral, they're telling the insurance plan to pay this specialist because I sent this person to the specialist.
Right. This is not an elective visit to a specialist.
Yeah, she or he are not making up on their own that I wanted them to go there, and so please pay the specialist.
Sure.
And the specialist anyway. So that's the referral. The next thing is if they give you just say go see a physical therapist near you, then you're correct. Then your insurance plan, if you have one, oftentimes they contract with different physical therapy groups. And so you want to stay in network to get the most amount of benefits for what you paid for, what your company's paid for. Just because there's good physical therapy or they advertise or they're nearby or they have a lot of offices does not mean that they're the best within your insurance plan. Right. And even within physical therapy groups and chiropractic groups, they use different philosophies and different techniques. I know it's kind of overwhelming, the McKinsey technique and myofascial release techniques and a bunch of different names and different techniques out there. So don't give up if it doesn't quite work out for you. Sure.
Well, okay, so that kind of, we're kind of getting ready to wrap up here, but why, I think that this will be a question probably on people's minds for any of these, like, functional issues, like my back hurts and it's difficult for me to move around.
Right.
Why does my physician or therapist or whatever want me to keep moving? How is moving more going to help it hurt less when it hurts when I move?
So decades ago, we used to put people in bed rest for weeks and months, literally months. We would put people in bed rest for bad backs.
Wow.
What would happen is that their pain would somewhat get better, but they would lose all their muscle strength all over.
Wow.
So these people had a hard time structurally reaching and bending and twisting because now everything was weak, and so now they were more likely to hurt themselves because they became deconditioned. So what we certainly want people not if you need no more than probably 2 or 3 days in bed or stuff like that, but for acute low back pain like this. And then we want people to get up and walk. We don't want you necessarily to lift and carry and do push-ups and sit-ups or anything like that. In fact, sit-ups are probably bad for you, for your back. They are bad for you. What we want is to be able to make sure, and one of the biggest things for any chronic pain, especially low back pain, is to walk.
Right.
Certainly if you have leg discrepancy or arch problems or knee problems or hip problems, you want to get those addressed. But it turns out walking is one of the better things. The other thing is also for weight control. So it turns out that's why all women who gain weight during their pregnancy, back problems are a humongous thing because your S curve, your gravity curve, and that's another thing that's a visual. Your from your head to your tailbone is not a straight line. It's a zigzag of back and forth, so that it's kind of a shock absorbing zigzag of your vertebrae. So it turns out to keep your back straight is not technically, even though it may look straight from the outside, it's not how it curves on when we look at X-rays and stuff like that. So it turns out that good posture when sitting, good posture when sleeping. A lot of people need to sleep like I do with 2 or 3 pillows underneath my head, hugging a pillow between my knees if I'm sleeping on my side.
Yep. A lot of pillows.
Right, lots of pillows. And how we sit and how a lot of us are with our head hunched over, texting or typing. So there's a lot of much better posture for not just our low backs, but for our necks and our shoulders and our wrists. So ergonomics is extremely important. But the other thing that we have, a lot of people are worried about this big C, the cancer word. And so certainly, there's no way to guess or get. That's what you tell the doc. I worry, my mom had cancer. I'm like, but you're 27. But my mom had cancer, but she was 85. But my mom had cancer. Fine. So that needs to be addressed about even if it's just to have you come back and so make sure that everything corrects, even if they don't do anything to look for cancer because they don't think that you're at a risk, even despite a family history or whatever. Right. If you've had a history of cancer, breast cancer, melanoma, those are at high risk of going to bone. Renal cell cancers, prostate cancers. Those are at high risk of going to bone. So it's certainly within the last 5 years, if you had any of those, no matter what your age, that's always a consideration.
Sure. Okay. Well, we covered a bunch of stuff here today. I think that, I'm just glad that we got to use Layla's example here. Thank you very much for coming up with an excellent case study, Dr. Tadros. Yeah. So I'm going to kind of give us run down a little bit of conclusion of what we want people listening to this to take away from this when they're going to their doctor, their physicians or whatever with their own, acute issue that maybe is not as straightforward as a sinus infection or something like that. So number one, understand how the doctor is thinking. They have medical and non-medical concerns that they're thinking about. They are very focused on objective sources of information, including observation, your history, vitals that they can measure in the office. But they also want to take into consideration your theories about what could be happening to you as well. They want to
examine you and also what your belief system is. That's right. Of
course. So you want to listen to possible diagnoses and explanations with an open mind. And it's important for you to understand when you're listening to that this may not be a complete list, right? That's right. The doctor is often nurse practitioner or whoever is often focused on the most likely scenario. That's right. And they are ruling out emergency situations or anything that needs to be treated immediately. So they are definitely doing, weighing those issues for you as they're giving their diagnosis. So Have reasonable expectations for appointments. If you have a common sort of regular issue such as back pain, don't go in expecting, your first visit for your complaint expecting a steroid shot or an MRI.
That's right.
That you might come away disappointed.
That's right.
And a great way to have a reasonable expectation is to go in with a clear intention of what you want to come out of the appointment with. It may not be a reasonable intention to, it's like, I'm going to get a steroid shot out of this.
Sure.
But a reasonable intention would be, I'm going to get my questions answered about what could be causing this.
Right.
And I'm going to leave with a plan of action to understand what I can do to help with this and what I should do going forward.
And sometimes instead of a steroid shot, which oftentimes is not helpful and has not been shown to be helpful for long term, this is a variety of different steroid shots for different back conditions. But sometimes it's that you get a Family Medical Leave Act to cut back on certain types of work,
Sure,
or give you time off of work and stuff like that. So I know it becomes a financial issue, but yeah.
Absolutely. You want to listen carefully to red flag symptoms, and make sure you have a list of those, or to pay attention to them, or bring a person with you to the appointment that can pay attention to those things for you.
Fevers, chills, night sweats, weight loss. Your pain gets worse whenever you try to recline. Things are getting worse over time instead of better, so gently better, according to what the time scale the physician laid out for you, the nurse practitioner laid out for you.
Be prepared for and open to non-drug therapies for common conditions of typical severity.
That's
Obviously, there are other outside things, but normal, run-of-the-mill, everyday back pain. There's a lot of this is going to be kind of at-home stuff. Keep moving, which works for a whole lot of issues. Do not just lay up in bed for weeks on end, and that causes other add-on issues. Utilize your insurance company's website or phone number to find resources for non-drug therapies. So those might be, they might have specific resources for other types of therapy for treating low back pain, for example. Or if your doctor says, hey, I want you to get physical therapy, you can use your insurance company's resources to find a therapist that's in network that'll be covered for you under your plan. And then finally, prevent what you can by staying active. So being strong and flexible, eating a well-balanced diet, maintaining a healthy weight, which decreases stress on your musculoskeletal system, and minimizing physical and mental stress.
Yep. Stopping tobacco.
Absolutely, stopping tobacco.
And like you said, so some core strengthenings may be helpful, and also some flexibility. Some people are not flexible because they're power lifters and stuff like that, but the rest of us need to be flexible, have to be able to appropriately bend down and lift with our knees and hips, et cetera. So which means
good mechanics,
which means that we have to have a certain level of flexibility at your knees and your hips. And that's one of the problems we see as we grow older, is that people have sacroiliac joint and hip and knee problems, and therefore they can't bend over, they can't squat down, therefore they tend to bend over and use poor mechanics. Yeah, that's right.
Absolutely.
Very cool stuff.
All right. Well, I know this was kind of a beast of a topic, but I hope this is giving people kind of a framework to think about their own issues, and also, giving a sense of empowerment, that you can get your issues addressed. As we always say, there are always hope and options in healthcare, physical and mental health, both. Dr. Tadros, thank you so much for talking to us about this today.
Yeah, it's fun.
Of course, if you want to get involved with the pod or have any questions or suggestions for us, you can shoot us an email at notyourdocpod@gmail.com. That is notyourdocpod@gmail.com. We are going to sign off for now, and we'll see you next time. Thank you so much.
Bye-bye. This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.